the recordings available to people who can't be here tonight or this morning. And I do want to really thank Graham and the team for their very kind introduction as well. It's a real honour to connect with you all. Thought that we would share some background information about Clan and the work we're doing with another movement called Mates for Kids as well, and share some practical information, tools and resources that we use. And then at the end, just share any opportunities or explore with you opportunities for collaboration, how you might like to see that happen. We do have recording on, and we'll just share that with Graham and yourselves and the partners for anyone who wants to look. But we do also encourage people to use the chat as well. And I've got a few little questions throughout to try and make it a bit interactive, so it's not just me talking. But then please raise your hand if you have a question. But otherwise, at the end, hopefully we'll have a bit of a talk as well. So in Australia, we like to start by acknowledging the traditional owners of the lands that we are speaking from. And I live not far from Graham in Sydney on the lands of the Wallumattagal people of the Eora Nation. So I'd like to pay my respects to the traditional owners of the lands here in Australia, pay my respects to their elders past and present. I'd also really like to acknowledge the team and partners that Clan's had the privilege of working with for so many years. And you met Maria Craig and Angie Middlehurst. They've been instrumental to Clan's work over many years. And it has been a real honour, as Graham said, working with Life for a Child since 2007. So we did this all together, but please feel free to share this information in the chat as we go. And if you have any questions, please feel free to share them in the chat. And Kath's going to be keeping an eye on the chat as well. So a brief introduction to Clan. It's an Australian not-for-profit organisation, and we started in 2004. So this is our 21st year. So we're a little bit younger than Life for a Child, but 21 years is a pretty long time. Now, Clan is really passionate about equity for children living with chronic health conditions. So we understand that in high-income countries, families can access the treatment and the medicine, the healthcare that they need pretty easily. But in lower income countries, we understand it can be very difficult for children with any sort of chronic health condition that requires ongoing treatment. And diabetes is obviously a classic example of that. But there are many, 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 many other types of chronic health conditions. And it's estimated in Australia that 1 in 4 children have a chronic health condition of some sort. So Clan is very committed to ethical, transparent management. We're part of something called ACFID, the Australasian Council for International Development. We're compliant with their code of conduct. We're in special consultative status with the UN's ECOSOC and WHO's Civil Society Commission. We're an active participant in the WHO's Global Coordinating Mechanism on NCDs, non-communicable diseases. And we're fully compliant with lots of different Australian regulations around finance management. And I just share all of that just to say that as an NGO, it is really important to have your house in order, and that is really important to Clan, and we work hard at that. This is the most important part of Clan, though. And this framework, our strategic framework for action, came about from consultation with families in Vietnam in 2005. And we asked families of children with congenital adrenal hyperplasia, what did they need to help their children have the highest quality of life possible? And the families told us they need 5 things. Number 1, they need access to affordable medicine and equipment. Number 2, they need education for themselves, for their family, for their doctors, for their government, for the world. They also want research and advocacy. They said, number 3, they want the best quality medical care for their child. Number 4, they want a strong support group. They want to be with other families who understand what they're going through. And number 5, they want to be free from poverty. They want to be able to afford to care for their child themselves. And CLAN acknowledges the United Nations Convention on the Rights of the Child, and we work with as many different stakeholders as we can, so government, the private sector, NGOs, families, doctors, the UN, whoever we can work with, universities, to help the families, and they're always our central focus, to help these families and these children enjoy the highest quality of life possible. So some of the benefits of this approach is the rights-based approach. We always keep the children, the community at the centre. We identify all children in a country living with the same condition as members of a community. We use the 5 pillars to guide everything we do. This framework has not changed in over 20 years. We believe in strengthening communities for sustainability, multi-sectoral partnerships. We have a strong equity focus, and we have now adapted this model over many countries and many conditions over the years. And I'll share with you now some photos to explain what does this framework look like in real life. So in Vietnam, for example, this is what it looks like for congenital adrenal hyperplasia. And the reason we started on that condition is my son has CAH. So he was 5 years old and he was having a good life with CAH in Australia. And I read stories on the internet of children in Vietnam dying of CAH and becoming very disabled and stigmatized with CAH. So that's when I traveled to Vietnam to understand it. And when we spoke to families, access to hydrocortisone and fludrocortisone were major issues. So we arranged a humanitarian donation for every child in Vietnam with CAH, a bit like what Life for a Child does. So there were about 100 children in Vietnam at that time. Then we translated some educational resources on CAH and how to care for your child with CAH into local language, in Vietnamese language. At that stage, there wasn't anything available. We prepared flyers, information for families on the rights of children with CAH and chronic conditions. We worked with WHO to get hydrocortisone and fludrocortisone on the WHO's essential medicines list for children so governments could start importing it themselves. We advocated, and I was very fortunate to speak at the UN around the NCD discourse, and I'll talk a bit more about that later. We trained up health professionals. We ran family support groups. We encouraged families to get health insurance, and we encouraged children. Here we are giving children awards for going to school. So we enacted this whole strategy with a whole lot of different partners. And I would say now, nearly 20 years later, there's now just over 3,000 children alive in Vietnam. No children with CAH in Vietnam have died since 2017. And the government does a wonderful job with all the medicines on the National Insurance Scheme. And I would say children in Vietnam now do enjoy a quality of life on par with that of children in Australia, which is to say it is possible to drive transformational change across a whole country within a generation. So we're very passionate about the fact that change is possible. So we were then asked by Vietnam to do the same thing with diabetes in Vietnam. And initially I said no. And then I rang Graham and asked him to help. And at that time, Life for a Child was full. They didn't have capacity to take another country on. So we then worked with Insulin for Life, we translated resources, we trained up health professionals, and you can see we just did the same thing again. And in Vietnam now, and I would give all of the credit to Vietnam and the Vietnamese government and the Vietnamese health professionals and the Vietnamese families, because the insulin is now on the National Insurance Scheme. The families get free access to syringes and needles. They have great education of health professionals and families. They're starting to get some pumps. And I would really acknowledge here Maria Craig, who's gone over and done so much education with the doctors and families here over the years for diabetes. And I would say quality of life for children with diabetes in Vietnam is a lot better these days. Then we were asked to do the same thing again for osteogenesis imperfecta. And I think now you can start to get a feel for this. This is the same thing. So We needed to, with medicines, we gave in countries where we needed, for example, in Indonesia, when we started, it was illegal for doctors to give bisphosphonates intravenously. So the doctors had to work with the government to make it legal to give the bisphosphonates. We donated bisphosphonates to start with until the government started buying the bisphosphonates themselves. We translated resources into Vietnamese, Urdu for Pakistan, Bahasa Indonesian for Indonesia. We brought families together as communities, and the Fostio community, that's their name in Indonesia, is especially strong. We helped them to celebrate Wishbone Day on the 6th of May each year. This is the OI community of Pakistan. And the OI community in these countries now is completely independent. I would say we watch their celebrations each year, and I'm on their WhatsApp group. They have a WhatsApp chat in Indonesia that is sending photos all the time. But these communities are now very strong. And I would say before we started, most of the children were dying before they were getting the bisphosphonates. I did my doctorate of public health in Vietnam, and I did hope to do it on CAH, but the government said they didn't want me to do it on CAH. They wanted me to do it on nephrotic syndrome, which was interesting. So we then did the same thing for nephrotic syndrome. And so I don't really need to now, I think, explain to you all the different things we did, but we just enacted this framework again for nephrotic syndrome. And we went from the hospital wards were full. There were 3 children to every bed. There were 80 presentations a day of children in relapse with nephrotic syndrome. There were over 3,000 children across the country that we knew. We did a health needs assessment. I surveyed over 430 families and interviewed 45 families to understand the challenges, to listen to them, and then to work with the government, work with the health professionals, work with other NGOs like NephCure around the world to then respond to what the families were saying the problems were. And the families now can diagnose a relapse at home. They've been taught how to test their urine. They understand how to manage nephrotic syndrome. And actually, the doctors in the kidney ward were a bit cranky because their ward became so empty that the hospital started giving them all the pneumonia and the gastro patients because they had so few children in the ward. So it was exciting to see change quite quickly. So I would welcome you in the chat to add, you all obviously work in diabetes, but I'd be really interested to hear from you in the chat. Are there any other endocrine conditions that are a priority for you in your country? Or are there any other chronic conditions? I talked about nephrotic syndrome, which is not an endocrine condition, but please feel free to put it in the chat what the priorities are for your country. We're interested in learning that. So one of the things I'd say about Clan's experience is how important community development is. Because when you start growing strong communities at the national level, then you can grow them at the regional level, then you can grow them at the global level. And I would say that CAH in lower income countries is shifting from being a very small, powerless community, mostly because everyone was dying. And gradually now I think it's growing, and we are definitely connecting globally. But this is the CAH community of Fiji. We've now started in Colombia, Vietnam, Pakistan, Indonesia, Zimbabwe. This is nephrotic syndrome in Vietnam. But communities are key, and we encourage communities to come up with their own name. Fostio in Indonesia, or CLIP in Pakistan, Sapi in the Philippines, and for people to form their own local organisations and logos. This isn't about having clan in every country. This is about locally grown communities growing stronger and stronger. And when we have strong local communities, then we are more powerful to advocate at the global level. So this is the work that we did as NCD Child. In 2010, we became aware that the United Nations was bringing member states together for the very first time to talk about chronic diseases in 2011. And when we first read the draft declaration, there was no mention of children. So they would talk about adults getting diabetes and adults getting cancer and heart disease, but never talk about children. So we worked with UNICEF, Save the Children, the American Academy of Pediatrics, a lot of different groups, Harvard, to form something called NCD Child, and we ran a lot of events and we advocated. I had the privilege of speaking at the UN. And the UN now does acknowledge, since 2013, that children can die from treatable non-communicable diseases such as rheumatic heart disease, type 1 diabetes, asthma, leukemia, if health promotion, disease prevention, and chronic care, comprehensive care are not provided. And this is really important. It's crazy to think 2013 was the first time that member states acknowledged that. But that now gives us an opportunity to have a platform for advocating for children and their rights to healthcare globally. So I want to briefly talk about Mates for Kids, which is a movement that CLAN started in 2021, and actually in response to learning about the situation for children with CAH in Zimbabwe. And we were really sad to see that children were dying and it was so difficult to get medicines and quality of life was so poor. So we started up a global approach to implementing the framework. So instead of just focusing on one country and a community in a country, now we're looking at communities at a global level and also regional levels. So WHO has 6 regions of the world: Africa, the Americas, the Western Pacific region, Southeast Asian region, Eastern Mediterranean region, and the European region. And we keep the CAH community at the middle. We work with a lot of different stakeholders. We come together every quarter for a community of practice meeting to talk about what we're all doing. And then we focus on 3 key objectives: access to medicine, building strong communities, and scaling newborn screening, because we know newborn screening's really important. Where did we get those 3 things from? We're really informed by the WHO's building blocks. There are 6 of them. And you'll notice that access to medicines, building strong communities, and newborn screening as part of health service delivery are 3 of those building blocks. And of course, we still do focus on strengthening the health workforce and information and data and finance and governance. But if you'll see that those 3, we've really chosen 3 particular building blocks as really key to our goal of reducing the preventable mortality associated with CAH by 30% by 2030. And where did we get those numbers from? From the SDGs. So member states have committed to SDG 3.4, reducing mortality by 30% by 2030 associated with NCDs. So in our 20th year, we're working towards 2030, and we're looking at, we've done the maths of countries we need to work in to achieve this, and we're aiming to give some community development grants to 40 countries by 2030 to help them drive this change in their country. So you can see here that CLAN started in 2004. We're here in 2025. We started Mates for Kids in 2021. We've given around 14 or 15 grants so far, so we still have some more to go. So we're very interested in working with new countries who have children with CAH who might like to get involved. And you can read more about Mates for Kids and the work that we're doing and the community development grants that we have available on our website, matesforkids.org. And there are some reports on some of the incredible work that's happened. And I'd like to acknowledge Dr. Priska and the team in Zimbabwe, because they really are leading the way, I would say, in many ways. So if you would like to write in the chat how many children you have with CAH in your country, we would love to hear that. So the last part of my talk, I just briefly want to share with you some different tools and resources we have that you might find useful. So one is the strategic approach we have to access to medicines, and we've done this for CAH, for diabetes, for osteogenesis imperfecta in the main. They're the main ones we've worked with. But in the short term, we give a catalytic humanitarian donation. So a short-term donation to keep children alive, while local champions work on longer-term solutions. So medium term, we want the drugs registered in country and on the National Essential Medicines list. But longer term, we want the medicines on the national insurance list. And I told the story from Vietnam, and you can see that they have achieved all of those steps. And it takes a long time to do this. Pakistan now has local manufacturing of hydrocortisone and fludrocortisone, for example. So does Indonesia. Different countries go about their solutions in different ways, but we have some documentation and resources to assist with that. We have a checklist that we give local partners to help them work through the different steps to achieve long-term access to medicine. And again, if you want to write in the chat, if you have problems accessing hydrocortisone or fludrocortisone in your country, we'd be very interested in hearing about that. So on pillar 2 around education, a couple of things we wanted to share with you. We have the Mates for Kids toolkit, which is on the Mates for Kids website. And we also work with the WHO's Knowledge Action Portal. And Kath, I might even ask you to put a link to the CAP in the chat, or I can do it later. But we have a platform on the CAP, it's called, and that's a great way of connecting people around the world. And if you're wanting to read more about those things, that might be useful. Pillar 3, as you would have seen, Maria, Angie, they've all traveled around to Vietnam, Indonesia, Pakistan with us, doing lots of education of families. So face-to-face sort of training of health professionals, but also at club meetings is really important. But we also run a lot of events. We try to align with UN events, and we try to have experts on different topics from around the world speaking. We're also working with one Australian NGO called TPA, Taking Pediatrics Abroad, and they can do some sort of small focus group education sessions on topics that are priorities for countries. For pillar 4, we have a checklist, and this is on the Mates for Kids toolkit, and this outlines, it's a tool to help countries plan for their club meeting. We worked with Colombia planning their club meeting, and it was a huge success in 2023. We usually suggest it takes about 6 months to plan for a club meeting because you're doing a whole lot of activities on all 5 pillars. It's not just an event. It's not just a club meeting. It's not just a party. It's actually a strategic event where you're working on all those different elements and bringing it together at the club meeting. The club meeting is a culmination. For example, you work to get ethics approval for a survey to consult with the families in advance, or you might invite the Ministry of Health to your meeting to help with your advocacy on access to medicines. You might invite the media to your meeting, for example. So there's a lot of planning that goes into a club meeting. And the next one is to share something called the Check Scorecard. This is another tool that we find very useful. And again, we're using this in Zimbabwe at the moment. This came out of my doctorate of public health when I surveyed the 400 plus families with nephrotic syndrome. I came to understand that those families were actually survivors. And so did some data analysis to understand why were the children surviving? And it was as simple as the social determinants of health. Where did the families live? Was it a single parent family? Was the family from an ethnic minority group? What was the parents' level of education? It wasn't, what was the 17 OHP level, or what was the kidney? It wasn't even what was the kidney disease. It wasn't any of that. It was the social determinants of health. So we have this 10-point, very simple checklist asking families these 10 questions. And we use this when we have limited resources. For example, if we have 30 children, but we only have enough free medicine for 10 children, whichever children have the highest check score, whichever children are the most at risk, the most vulnerable, they are the ones that get the medicine. So it just helps us in a quantitative way to prioritize, to bring an equity approach, I guess, to the work that we do. And pillar 6, which is our secret pillar, which is all about ethical and transparent program management. We have a range of indicators and scorecards and tools that we use to track progress. It's very important for us to know how we're tracking towards 2030 to achieving our contribution to the SDGs. So I won't go into these tools in a lot of detail. You can see the check score is one of those. But happy to share any of those tools with people as well. So that's really all I wanted to share to start with, and just to open it up to conversation and questions. Different ways that we thought that we could collaborate from here. Mates for Kids has our next community of practice meeting on the 11th of December, and you would all be very welcome to come along and have a listen and see what the CAH community globally is doing and how we're working together. And if you want to invite members from your CAH community to join, they are very, very welcome. We have the Mates for Kids Community Development Grants, as I mentioned. And again, you're very welcome to work with the CAH community in your country and to apply for one of those grants. We're happy to facilitate regional connections or even international connections. For example, if you're wanting to work on osteogenesis imperfecta, we can connect you in with key people around the world who are doing that. We don't tend to work so much with diabetes because Life for a Child does that, but very happy to support with questions, specific questions you may have. We'd really encourage you to explore the WHO's Knowledge Action Portal. I think from a diabetes point of view, the NCD discourse is very powerful, and I'd really encourage you to engage in that NCD discourse and connect with other civil society groups like the NCD Alliance. We do offer mentoring as well. So if you're wanting to meet on a regular basis, for example, if you're planning a club meeting, we're very happy to meet as you're doing your planning, because sometimes that can be really helpful to talk things through. And I think that worked really well for the team in Colombia. We are developing some online developing some online learning modules, and they're to come. And as I mentioned, we'll share this recording as well. So really, that's all that I had to share. Welcome any questions or discussion. Just wanted to leave time to have a bit of a yarn. I'll stop sharing my screen there. But yeah, very much welcome any questions. I'll have a look at some questions in the chat there as well. Thank you, everyone. Everyone's been busy. Priority areas: disorders of sexual differentiation, rickets, thyroid diseases, rare disorders. Yes, thank you. We do have a team in Africa, Clan Child Health Africa. It's incorporated in Uganda, and they are working with the African Society of Pediatric and Adolescent Endocrinology, ASPE, on that. But thank you for that. DSD should be considered a future priority. And we're very excited that teams in Africa now are connecting with ASPE and with IFCA, a group called IFCA internationally. They're in France, and they give $100,000 grants for research, and Africa is looking to apply for a grant. So that's exciting, and hopefully they'll do a lot more on that. Newborn screening. That's a really good question, Dr. Barker, and I will try and connect you with Dr. Abiola, who we work with, because they have applied for a grant from Clan, and they are working on that. And yes, we do have connections with newborn screening groups internationally. WHO has an increased focus on newborn screening now. And there was a resolution that came out at the World Health Assembly just last year on newborn screening, and I'll share that resolution with everybody. We understand it's very difficult to get heel prick newborn screening programs in many countries, but WHO is really advocating for a holistic approach to newborn screening. So even just, head-to-toe physical examinations are really important, and having strong referral pathways around that. We do have a lot of events on newborn screening, though. We try to raise awareness and we try and connect people internationally who work on newborn screening. And we have given a grant to one amazing group who in the Solomon Islands, who have just started cord blood testing for hypothyroidism in the Solomon Islands. I was just speaking to their team today. That's very challenging. It's hard. There's no easy answers there. I think that Uganda's got some great work happening in the field of newborn screening, and I think there's some other countries as well in Africa who are doing some great work. So I will share some information on newborn screening. Zimbabwe, I'm just looking at the Dr. Priska's tertiary level's good in picking up who needs screening. Peripheral clinics is still a challenge. No newborn screening yet. And I think very, very few lower income countries have newborn screening for CAH. In Uganda, they're doing a project that they have support from the big hospital, biggest children's hospital, around doing some education of health professionals on visual screening for CAH in newborns. Advocacy, mentorship, and collaborations are necessary. If anybody wants to put up their hand, and so that it's just not me talking, I feel bad that I'm the only one talking, but I'm just looking at all your great questions. It's biggest challenge is diagnostics as well. Do you have to? Yes. What sort of diagnostics, Dr. Priska? In addition to the work being carried out by social support, yeah. Did you want to talk to us, Emmanuel, about the work that you're doing there? Oh, it's Emmanuel. Oh, no. Emmanuel, did you want to talk about the great work you're doing there?
Oh, yes.
Please have the floor. We'd love to hear from someone other than me.
Thank you so much. Again, Emmanuel from Liberia, West Africa. We have a program that is being sponsored by the World Diabetes Foundation. In Liberia, we run in 14 counties. Liberia has 15 counties, but we have one of the international organizations that is working in one of those 15 counties. So for the past approximately 6 years now, we've been working at the national level with our key partners. Ganta United Methodist Hospital, with key partners like the NCD Alliance of Liberia, the Liberia Diabetes Association, and our most technical partner is the Ministry of Health through the NCD division. So I serve as the project manager for this joint partnership project. And there are several areas that we are looking out for support. I just listed a few of those areas in my message in the chat, which you will read. But generally, social support is needed, especially for the facilities being sponsored by Life for a Child. As you may know, I will be remiss if I cannot recognize the effort by Dr. Graham and his team at Life for a Child. They started in Liberia since 2011, with Ganta Hospital being a sole recipient of their donations. And then those donations were given to other facility. So since 2011, Life for a Child has expanded its operation to several facilities through Ganta Hospital, and we much appreciate the effort of Graham and his team. So like he said earlier in his opening remark, one of the areas where they do not support and we found it as a priority area in addition to their effort is the social support. And that include trying to prepare those young people, knowing that not all of them will be able to have college education. Even in Liberia, those who do not have chronic conditions, not everyone goes to college. So preparing them so that they can be useful in the community is one of the priority areas. In addition to that, I also making sure to develop programs that will help them to be self-sufficient, because do not will not be able to provide all of the donations for the lifetime of someone living with diabetes. So there's a cut-off point, and before that time, those children need to be prepared, knowing very well that Liberia is a poverty-stricken nation, and being living with chronic condition that follow exacerbates your lack of basic social services. So we can talk more about that. I just don't want to take too much of your time, but I appreciate this opportunity to share with you what we do in Liberia, and also what are all our priority areas that we think that if it is aligned with CAN mission and payloads, we can work together to see how we develop partnership around that. Thank you very much.
Thank you so much, Emmanuel, and congratulations on the really excellent work you're doing. And this is exactly the sort of thing that we're really passionate about at Clan. There's a couple of things that come to mind. One thing is that I would invite you and anyone who wanted to join, for that matter, to join we have fortnightly meetings as Clan Child Health Africa. So Clan was incorporated in Uganda, and unfortunately, Dr. Andrew Twinamatsiko and Dr. Esther Coble, who Esther's a pediatrician and Andrew's a general physician, they haven't been able to join us today, but we meet with them every 2 weeks as a team, and we have members from Zimbabwe and Kenya and Uganda who join. And they are the group that if we have queries or partnership requests from Africa, they go through the Clan Child Health Africa team, and they're a wonderful team. And they have been working with the epilepsy community in Uganda, as an example, and have been doing some really remarkable microfinance projects, raising chickens, poultry, and using that as a way of helping families to afford medicines, and really looking at innovative solutions. So really appreciate the work that you're doing. I think that they would be really interested in the work you're doing with NCD Alliance as well. So would very much welcome the chance to join and to keep sharing ideas. The good thing about the UN events, because Clan is informal special consultative status with ECOSOC, it gives us the opportunity to host UN side events, and we do that on a regular basis, at least 2 a year. And that gives our speakers a platform to be heard, as well as the WHO Knowledge Action Portal. So that's a place where your great stories can be heard. And that's a really powerful way. We're really passionate about bringing stories from the grassroots and letting the most important people, well, not the most powerful people in the world hear about it. The other thing that might be really helpful for you, Emmanuel, is Clan's club meeting checklist, because if and that's where Clan might be able to give a small community development grant, because we find that if you take a strategic approach to planning your club meeting, and we've done that for diabetes, and Ange and Maria and Graham know all the diabetes people in the world and could help with the planning and connections and networks, you can end up having a really powerful event where you can really raise the voices of the people in the community, help them to combine and connect and identify their own leadership structure and so forth and so on. So they're just a couple of ideas that come to mind, Emmanuel, but we'd really welcome the chance to keep talking with you. Dr. Priska, I totally agree with you about 17-OHP. And I think that this is an example of something that we've been raising through ASPE and also through the IFCAR grant. We're hoping that there might be able to be something that comes through that. Access to carrier typing is another challenge that we've heard a lot about. And so we're exploring sort of partnerships with groups in Europe who might be willing to do some very affordable testing. But I do think that ASPE is our greatest hope in terms of advocacy in that space. So that's where Dr. Esther is really working quite closely with Candy and a lot of the others that are in that network. So I'll mention that to Esther as well about the 17-OHP. And point of care testing, Dr. Barco, did you want to talk about your work in newborn screening? Oh, have we lost her? Oh no, there she is. Dr. Barco, did you want to talk about your work with newborn screening and the work you're doing in rural communities?
First and foremost, the foundation I started, let me use the word started, is not being specific to particular diseases. And we came in with the idea because we realized that there was some kind of gap between those who could have access to tertiary secondary institutions and those in the rural communities. I have been part of the diabetes community. I'm also serving at the national level, but I observed that most of the children in the rural area
Can anyone hear Dr. Barco? Are you still there?
hear me.
Oh, sorry. I'm not sure if it cut out, but so your
Hello?
focus, yes, your focus is on rural areas, you were saying?
Yeah. So I know we have a lot of, the chairman of the board of trustees of the foundation is an endocrinologist. We have pediatric endocrinologists as well. The question now is, CAR, as you promoted, I don't want us to start with collecting funds from clan. I want us to start with advocacy. Are we, now that we're already trying to organize a medical outreach next month for World Diabetes Day, can we have access to some of your materials, like descriptive materials that will explain to the ordinary man on the street, a layman, what CAR is, what are the symptoms, and they would be able to pass the message to other people. We can actually keep those posters in rural hospitals, and the ordinary man that has never had access to a pediatric endocrinologist will look at it and see, when he sees that symptoms elsewhere, he'll be able to relate to the condition. That's, for me, that's where I would want us to start. Then if clan is willing also, we would want to engage the media. We can actually dedicate funds for the media in local languages and tell people this is what congenital adrenal hyperplasia looks like. These are the symptoms. This is what you can do to prevent it if a child can get newborn screening, so that when the newborn screening starts, in quotes, it wouldn't look odd. People will see reasons and agree with us that, okay, it is necessary for the test to be done. So I think those are the two places we can start for now, to be able to reach the rural people, the people at the grassroots who have no access to to good healthcare, who can never be in Nigeria, cannot be on the national health insurance scheme. Because as it is, the national health insurance scheme is basically for those who work with the civil service in Nigeria. So sometimes affordability becomes a very big challenge. It's a huge one. I was telling someone just recently that the cost of a glucometer in Nigeria is more expensive than the minimum wage per month for a civil service staff. So how do you tell them to buy? How can you tell someone to use his whole earnings for a month to buy a glucometer? It doesn't make sense. So we need to decentralize. We need to look at how we reach the ordinary, the grassroots and assist them. Let's start with advocacy. Let them know what it is, so that we demystify their minds. And when such services come up, there would be less challenges, less people who want to like say, no, it's a myth or something. So I don't know. That's just my thought anyway. I don't know if Graham has any.
That sounds excellent. I'm very excited to link you in with the team in Zimbabwe. So Trudy is a wonderful lady there who heads up Zimbabwe's rare disease organization. And she helped us initially with our work with Dr. Priska to start work for the CIH community. And one of their first priority actions is exactly what you suggested. They did social media and plain language, simple communication for the broader community on what CAH is, and also for simple messaging to health workers and practitioners. So I will introduce you to them, because they have already developed up all of this material, and then you will be able to adapt it to local languages yourself. And also connect you in with Dr. Abiola and the work that they're doing also in Nigeria, in other parts of Nigeria, so that you can all connect together and perhaps come up with a shared approach to the media. Because there is one grant already in Nigeria, so it would be great to connect you all together. So that will be a follow-up item for us, Dr. Baker, to do that. Well, thank you very much, everyone. I'm mindful we've come to the end of the hour, and everyone's so busy. It's so generous of you to give your time. We're very thankful. Please feel free to stay in touch by email if you have any questions at all. But Graham, thank you again to you and your team for connecting us all. We've got some action items. I'll send an email out to everyone with the follow-up actions and also a recording of this meeting. But thank you very much to everyone for your time. We're very grateful to you.
And thanks, Kate.
Thank you.
I just one comment on I think some of your materials would be very helpful. I know you've got a lot, but the club checklist, I think that would be something interesting. It'd be very thought-provoking, even just to send that out, where we could send that out to people and say, well, this is just ideas. And I think I noticed at the end of your presentation as well, you were talking about how you were working on community development, sort of a process. Putting your thoughts together for that, I think that will be really helpful in due course as well, across not diabetes, but also these other conditions. So, but lots of possibilities. So thank you everyone for your time, and thanks so much to Clan for the partnership.
Thank you, everyone. Such a privilege to meet you all. Have a great rest of your day.
Thank you.
Thank
Bye-bye.
you.
Bye-bye.
Bye, everybody.
Thank
Thank
you,
you.
Graham.
Bye.
Bye.